On behalf of founders Rajiv Rebai and Paul Winston, we welcome you to CANOSC 2019. It is our goal to introduce cutting-edge novel interventions for the spastic patient. It has only been a few years since we were introduced to the work of Professor Terre Deltome from Belgium and his group, and their use of selective motor nerve blocks to predict the outcomes of treatment with spasticity models, and it has changed our practice. Traditionally, patients are treated for their spasticity at any given interval when they refer to clinic. They may be seen days, weeks, or years after their event. This is a patient who has developed significant spasticity after 2 weeks. What is the optimal treatment paradigm? Early intervention can be highly successful. This gentleman had a painful spastic arm after his stroke with very little movement. 2 years of treatment restored function very well. He still, however, walks with an associated reaction and a stiff knee gait until reminded not to do so. We know this would have become quite a significant problem had it not been treated early. Similar case of spasticity onset within 5 days of a stroke. After the stroke, chemodenervation was offered and he restored excellent range of motion in the elbow flexors. He has stopped treatment and no longer needs it, a successful outcome. This patient, who had anoxia and a stroke, had excellent results from botulinum toxin intervention over 1 course of treatment and never required it again. In dealing with spasticity, we often do not consider the fact that all muscles are connected to the central nervous system by nerves. Are there procedures to affect the nerve primarily? In 2017, we traveled to Versailles, France for a neuroorthopedic conference. We discovered that the francophone literature was extremely advanced with multiple procedures for spasticity, both surgically, interventionally, and had a very large body of literature in the French language that we were not aware of. However, this wonderful paper by the conference organizer François Genet looks at choosing the most appropriate muscle for a flexed arm pattern. In this case, it was a motor nerve block to the brachialis muscle. Upon return to Canada, we realized we needed to try this intervention. A group of physiatrists in BC asked 2 interventional anesthesiologists to help us with motor nerve blocks, as they were experts in ultrasound and we were also routinely using ultrasound. In Europe, it was mainly needle stimulation. On the left side of your screen, you see the musculocutaneous nerve of an interventionalist. Large, robust. On the right side, it is harder to find in a patient that has spastic muscles that have been chemodenervated, but with ultrasound and stimulation guidance, we are able to make excellent localization. Our first patient, you can see on the left, his first fast catch, or his V3, was about over 90 degrees. His active range of motion was only 70. After the injection, Dr. Rebai has a much larger range of motion. Dr. Vincent questioned with our wonderful success in these patients why we were not doing cryoneurotomies. It was not a procedure that we thought was possible. Dr. Vincent had been doing this procedure for 30 years for pain procedures. We researched the literature and found a case study from the 1990s and an unpublished series from the United States. This technique uses a cryoprobe, putting a -60-degree ice ball around the nerve, which causes Wallerian degeneration of the nerve. However, the epineurium is maintained so the nerve can regenerate. This patient is only 9 days post-procedure, and he's discovering that his range of motion, he can now actively achieve his passive range of motion. The patient continues to make gains, the 1-2 month interval, and at 6 months he is much improved with less clonus and more fluid movement. We've been able to move the botulinum toxin that was going into the elbow flexors to the hand. His hand is now opening much more easily and he has less pain and better function in the hand. And at 9 months, it actually has maintained and he is doing extremely well. We have been doing cryoneurotomies on multiple nerves for the past year. This is another patient with a musculocutaneous nerve block with lidocaine. You can see on the left side how much resistance there is to movement. On the right-hand side, her elbow flows very nicely, and she has both increased active and passive range of motion. This is with a small amount, 2 cc's of lidocaine. The patient also had a lot of difficulties with opening her hand and supination. She had been receiving botulinum toxin for several years. We added in a median nerve block in clinic with lidocaine. Her fingers opened more easily and we were able to supinate. This will now determine the course of her treatment. This is another patient who has severe clonus prior to intervention. She did not want any more botulinum toxin or surgeries. After a musculocutaneous nerve block, she had much greater range of motion and wished to have a neurotomy. So how do we do this? Here is Dr. Vincent introducing a needle into a tibial nerve. As he gets near the nerve, we turn on our nerve stimulator. This is an inexpensive small nerve stimulator, not one used for spasticity, as we need a very low current. The muscle begins to contract. The lidocaine is introduced and you see mechanical disruption and the movement stops. This patient has had both Achilles lengthening and many years of botulinum toxin with incomplete results. He still has clonus and incomplete range of motion. After performing the nerve procedure that you just witnessed, you can see how readily we can dorsiflex the foot and there is no more clonus. When he was trying to dorsiflex on the left before the procedure, there's limited range of motion. He's made significant gains in 5 to 10 minutes after the procedure. Now you can see him walking on the left foot. His left foot is often pointing towards the ground in a spastic equinovarus pattern. Post-procedure, he is clearing his foot quite nicely. He was recently hospitalized, was feeling weak, and the procedure will be repeated. This is one of our first cases of cryoneurotomy for a tibial nerve. This woman is only a few days after her procedure. She had a severely spastic equinovarus foot. She is now getting almost her full foot contact and learning how to walk with this. She will need gait retraining. Patients may not even want to go for any intervention. This man is 30 years after incomplete spinal cord injury. He was hesitant to try any treatments. A simple obturator nerve block to each side showed he did not have to have a spastic adducted walk, and we will now consider botulinum toxin as the next line of treatment. Patients that have had spasticity their whole life, such as cerebral palsy, are making gains. 20 minutes after a nerve block, this patient gained about 40 degrees range of motion. He was previously getting maceration in the arm that we hopefully will prevent. This woman with spastic cerebral palsy has a lot of stiffness and pain trying to use her left arm in abduction. A pectoralis block has made it very easy to move the arm, and she has gained active range of motion. Here is a patient with spastic CP who has a very painful fisted hand. He had maceration. Botulinum toxin injection by a physiatrist opened the hand, but it was painful and incomplete. Here we see our plastic surgeon assessing the hand after the median nerve block. Not only is there no pain from the procedure, but the hand is now resting open. We are easily able to put in this protection for the hand, and she has gained much greater range of motion. This patient is now able to have a selective motor neurectomy to the branches of the FDS or potential other to open the hand and reduce pain. Though he noted taking out the sensory branch was something he really appreciated with the block, as he doesn't really feel the hand, but he has pain. Dr. Emily Kraus, peripheral nerve and plastic surgeon, is a key component of our clinic. This patient with cerebral palsy has a flex wrist deformity and was referred to her. I performed an ulnar nerve to FCU nerve block, allowing for a much greater range of motion, and she can now consider a ulnar neurectomy. Similarly, on his left-hand side, he has increased tone, and a musculocutaneous neurectomy and an ulnar to FCU might be the simplest procedure with very little recovery time. What we know about partial surgical neurectomies is that plastic surgeons are very comfortable with anatomy. They can selectively choose the fascicles to the affected muscles. This woman on the right is post-op from a musculocutaneous and median neurectomy. She had gained 11 new functions she could use with that hand very quickly. Dr. Teltome has recently published an excellent paper looking at what is the best procedure for spasticity. This conference will serve to help us choose which is the appropriate treatment for each patient. It is likely a collection of all. I would also like to look at ultrasound with you here. As you can see, this is an ultrasound of a gastric soleus complex. Botulinum toxin allows us to selectively choose the gastric nemeus. On the lateral head, you can see how small and atrophied that muscle is. There are techniques, and we are going to be looking at, does muscle architecture inform our intervention? Is contractility available to be seen on ultrasound? Why are we doing this? Not only do we want to achieve greater range of motion and greater function for our patients, but we do know that just by lengthening the carrying arm, we can see changes in gait, speed, and momentum. Our experts from around the world will show us how laser is being used to perform neurectomies and tendon lengthening. We will look at cutting-edge surgeries from the muscle to the nerve to the tendon. We will be looking at the ultrasound architecture. We will be looking at casting workshops. We will be talking about bedside percutaneous needle stenotomies in care facilities. But overall, we want you to come to CANOSC, teach us what you are doing so we can all share to improve the outcomes of our patients.